The next set of debates are going to be on myopic tractional maculopathy. Dr. Simon SZETO is online via Zoom, so can we play his video, please?
Should be used as the first-line therapy for myopic tractional maculopathy. I would like to apologize that I'm not able to attend the meeting in person today, and thank the organizers for the invitation to speak. Here are my financial disclosure, none of which is relevant to today's talk. When we talk about myopic tractional maculopathy, MTM, we're not talking about one condition, but an umbrella of conditions that include macular hole, macular schisis, and vitreomacular traction. These conditions arise due to abnormal perpendicular forces from the vitreous and posterior staphyloма, and also tangential traction from contracted internal limiting membrane. To understand what is the best treatment for myopic tractional maculopathy, we first need to understand its natural history. It occurs in 8 to 34% of myopic eyes with posterior staphyloma. Generally, it is believed to be a slowly progressive disease with chance of spontaneously improvement. However, around 1 in 10 eyes may progress and develop drop in BCVA over 3 years. Surgery is generally indicated when complications such as foveal detachment, macular hole, or macular hole retina detachment occur. This diagram summarizes all the pathological factors exerted in the macula in MTM. And vitrectomy only addresses a few of these pathological factors. So what are the problems with treating MTM with vitrectomy and ION peeling? First of all, the success rate is generally low. There is also a risk of postoperative macular hole, and also it may accelerate macular atrophy. For example, in this lady with bilateral MTM, whom I treated both eyes with vitrectomy and fovea-sparing ION peeling. The right eye results was excellent. There was resolutions of macular schisis and also no postoperative macular hole. Unfortunately, the result was not so good in the left eye. There was formations of postoperative macular hole. This occurred even after fovea-sparing ION peeling. Postoperative macular hole in MTM will occur in approximately 1 in 10 cases. Although operations with vitrectomy has a success rate over 90%, the visual outcome is generally poor. And the success rate in macular hole in highly myopic eye is also much lower than in non-myopic eye, with a success rate of around 60 to 80%. For example, in this gentleman with myopic macular hole and posterior staphyloma, despite treated with vitrectomy and ION flap, the macular hole failed to close postoperatively. So in summary, vitrectomy and ION peeling have several inherent limitations when it comes to treatment of MTM. It may contribute to myopic macular atrophy, postoperative macular hole formation. It has a low success rate in high myopia associated macular hole, and it does not address the progressive elongations of eyeball or posterior staphyloma. And when we perform macular buccal, we are able to address the perpendicular forces exerted from the posterior staphyloma. Here are the reasons why I believe retina surgeons have not been doing macular buccal as often as they should. First of all, the surgical learning curve could be quite difficult to overcome. It generally requires specialized equipment, and some surgeons are concerned about the outpouching of surrounding retina and contribute to myopic glaucoma. Well, I believe that modern instruments make it slightly easier for surgeons to perform macular buccal with the incorporations of fiber optics. And also intraoperative OCT could be used to confirm the position of macular buccal. When specialized equipment is not available, there's a cheaper alternative in suprachoroidal macular buccal. And also, I believe that macular buccal could address the perpendicular tractions from posterior staphyloma, making it an ideal surgical option for complex macular hole retina detachment. In the past, performing macular buccal could be quite challenging because surgeons need to rely on primitive materials such as stainless steel or silicon sponge. However, in modern days, there are commercially available macular buckle that incorporates fiber optic, such as the AJR macular buckle. When these fancy equipments are not available, one could also use the alternative method to perform macular buckle by using the suprachoroidal cannula to inject viscoelastic in the suprachoroidal space. This is an example of macular retina detachment that was treated with vitrectomy combined with suprachoroidal buckle. As you can see, the anatomical outcome was excellent. This is another case of MTM with fovea detachment treated with combined vitrectomy and suprachoroidal buckle. As you can see again, the anatomical outcome was excellent. And a recent meta-analysis also showed that the macular buckle surgery has a good efficacy in MTM by improving best-corrected visual acuity, reducing axial length, which may counteract the progressive nature of MTM. And also it has a favorable outcome in macular hole closure rate and reattachment rate. And in a randomized control trial comparing primary macular buckle versus primary vitrectomy in macular retina detachment, it showed that the macular buckle has a higher retinal reattachment rate compared to PPP, although the postoperative VA and macular hole closure rate were similar between the two groups. This slide summarizes the reasons why I believe retinal surgeons should perform more macular buckle to treat MTM. Firstly, vitrectomy has inherent limitation and risk in managing MTM, whereas macular buckle could address the other pathological causes from posterior staphylomas. And for people who are worried about the safety or efficacy of macular buckle, I hope that the recent meta-analysis could be reassuring. And lastly, I believe that a good surgeon should be equipped with different surgical techniques so that when the challenges come, we can rise up to the challenge and face the difficult surgical scenario with the appropriate surgical technique. Lastly, I would like to thank my team and also my mentors from Hong Kong. Thank you.